So I will be talking about trends, and I'm starting out. I've got a little quote up here from Jack Kerouac. Most of us have probably read the book On the Road. He's the author of that book, and but Jack was definitely a different cat. He definitely liked to do things differently, and he was certainly a trendsetter of sorts. But I think if Jack was an employer, he would probably be out of business. It's very difficult to really go way out on a limb and set new trends. And if you want to be an employer, you've got to really kind of look at what's hot in the marketplace, kind of what's going on. And certainly you want to set yourself apart, but you've got to adopt a lot of what is already there. It's good to be a creator of things and to really kind of show yourself as being different. But at the end of the day, employees see what other employees get at other companies. They say, I want that. So sometimes you have to go for that, or you have to do what other employers are doing to retain and recruit talent. So just a little bit of an overview about what we're seeing for trend in the marketplace in general. So what is medical trend? And I talk a lot about what is trend with my clients. So trend is really the baseline factor number that insurers are using to determine what future insurance costs should be. It's basically a number over and above what they used last year for that baseline. And there's several components that go into it. There's certainly a general inflation component, but more importantly, as we drill down, it's the medical inflation components that go into it. And those are really broken out into three different parts. You have your inpatient and outpatient costs, which fluctuate at different rates each year, usually way up. Your professional services costs, that's really the doctor's offices and what their costs and how much they're going up each year. And then the other bucket would be the prescription drugs. And this is the real wild card over the last few years. You've probably heard either me say it or other people say how much prescription drugs continue to increase every year. It's at a rate that's far above regular inflation and far above medical inflation. And it's really one that insurers are doing everything they can to control, but it's difficult when we don't have a lot of drugs that are losing their patent status, where we have a lot of new drugs coming on the market that are very expensive, very effective, but very expensive. So it's a hard one to control. You certainly have government influence of things like taxes and regulatory fees. The big one over the last few years has been the HIT tax, the health industry tax, part of the ACA, and that tax comes back in 2018. We had a moratorium this year, so it, to some degree, artificially kept rates a little bit lower, but next year it comes back in full force, and it's going to add about 2.5% to all the rates. So it's a big piece that is weighing on the rates. And then there are some other things that go in as well. Then the other big piece of it is utilization. Utilization is how much healthcare are we going to use. So people have to predict, okay, we use this much healthcare in 2017, how much will people use in 2018? And usually the factor goes up every year about 2 or 3%, and that's usually what we see over a 10-year period. But last year it only went up about 2%. This year it went up closer to 4%, and that was above what insurers were using as a predictive number. So it really hurt the rates quite a bit. Insurers kind of missed the mark on that. Prescription drug trend was actually a little bit lower than they were predicting, so it helped to balance it out a little bit. For next year, PricewaterhouseCoopers study came out. They're showing a national trend about 6.5%. But as we know, here in New England, we run higher, certainly in Massachusetts. So we're looking at about 7 to 9% amongst the different carriers. So get a little quiz time here. Maybe you can kind of remember where trends used to be or what average cost of insurance was. And so looking at what the average annual cost of what an individual paid for insurance, the total premium, what was it back in 2000? So 17 years ago, what was the average annual premium for an individual on a group insurance plan? And I'll take 3 answers. And basically, whoever's closest will do the prices right, closest without going over. I'm buying them a coffee. So any volunteers on what it cost for an individual total annual cost in 2000? Darcy?
2,500.
2,500, okay. Anyone else gonna try? Yes?
5,000.
5,000, okay. One more?
4,300.
4,300, okay. I think everybody was a little bit over. Darcy was closest though. So it's 20, sorry, you were right under. Sorry, 2749. So you get this one. All right.
Like a price is right.
Yeah. And so now we'll do, what was it in 2010? Just 7 years ago. Who wants to take a guess? Yes.
5,500?
55? Anyone else?
7,500?
7,500? Okay. One more.
4,800?
4,800.
Huh?
54. You were 55, so actually James wins. I picked James, I thought he was going to say $1. So what is it today? 7,000. Just under $600 a month. So if you see that progression, it basically doubled from 2000 to 2010, and then it added another about 2,500 as it went from 2010 to 2017. Pretty big progression. And then on the family side, in 2000 it was about what it costs today for an individual. And then by 2010 at 14, and now 2017 it's over $20,000 for a family premium. So what are we doing about it? Cost containment strategies. I think of it as more of a progression, not an evolution at this point. We just don't see a lot of things coming out that says, wow, this is the magic bullet. You know, it's really taking what we've been using and kind of moving the arrow down the road a little bit. Consumer-driven plans, the shift has slowed. A lot of it is because we've already got to the bottom of the menu to some degree. There's just not a lot of tools left in that space. We're also not using the tools that consumer-driven plans have. And I think that's, you know, to some degree we've accepted deductibles as a fee we pay instead of a fee that we could manipulate. And I'll talk a little bit more about that when I talk about transparency tools on a later slide. Because transparency tools, cost estimator tools, they've gotten a lot better, but we're not using them. That's one of the things that needs to happen. There is a shift to self-funding. Large groups have already done this, but smaller groups every day are doing this. So there's more products in the marketplace that are available that allow smaller groups to do this, and it's a more efficient way to buy insurance, but it's not for everyone, and it's something that we talk about with groups. The insurers are giving the best incentives on products to products that have incentivized networks or limited networks. There are high efficiency providers out there, there are lower cost providers out there, and the products that focus care through those providers are the ones that you're going to pay the least for. A lot of times insurers put these on the market and the take-up rate's not that high. There's a lot of products in this space, but we just, you know, we always see them as the least popular ones. We're very slow to take that direction of limiting our network for our employees. Expanding plan offerings certainly is something that carriers are doing, but employers are doing it too. They don't want to take that great plan off the table, so instead what they do is they put a lower cost plan in place, peg their contribution on that, and let employees buy up to the plan they used to have. It's a very effective tool. It allows you to not take that plan away necessarily, and a lot of employees are happy with the lower cost plan. Maybe it's all they need, and you're giving those employees those choices. And then you're going to see a continued heavy hand in RX management. Insurers continue to put in different copay steering tools, higher copays, and then also hurdles. Drug management, where suddenly you go to the pharmacy and there's basically a new hurdle you need to go through to get a particular medication. They want you to try this other medication before you can go back to it. Or a doctor prescribes a medication and they want you to take something else first. You're going to see more and more of that happen in the marketplace. Now the cost estimator and transparency tools, a lot of people don't know this, but there's a law in Massachusetts that requires insurers to do this. That you have to be able to go to your insurer and find out approximately how much something is going to cost. And they have these tools online, and they've continued to refine them to the point that they're actually pretty good. The national insurers have always had them, or I shouldn't say always, but they've had them for a while. But each of the carriers here in Massachusetts do have these tools, and some of them are very effective. They come in kind of 3 different formats. The first format is a simple cost estimator based on the plan design that you have. And based on your copays, your deductible will tell you about how much this will cost. That next level will not only give you cost, it'll also compare it to other providers in the area and give you quality information in addition. And that way you can actually compare, well, if I have this at this hospital, it's this cost, but if I go to this hospital, it's actually going to save me quite a bit of money. You know, that's really what they want you to do. And truly with a consumer-driven health plan, you become a consumer as opposed to just paying your deductible and kind of shifting those costs around. If you're using an HSA, it's becomes really important. And then there's level 3, I call it. This takes that next level where the insurer is actually saying, if you use this tool and use it effectively and you choose the lower cost provider, we're going to pay you. We're going to give you an incentive, and we'll even rebook your appointment for you. Kind of a concierge stuff. This is actually, Neighborhoods is doing this for 1/1. Harvard does this in New Hampshire, and they do it on a limited basis here in Massachusetts in a large group, but you're going to see more insurers offer these type of tools. HSAs, the growth in HSAs has been extremely slow here in Massachusetts and throughout New England. A lot of that is our Yankee mentality. We don't like change. And HSAs are a little bit of a significant shift through our comfort zone. And also the premium differentials aren't that big. So when we look at HSAs, we have to look at it from the right perspective. Is it the right tool? Is it just going to, because it's the lowest cost thing? Because that's not really the best perspective. It's really the long-term aspect of the savings of an HSA, which is why some groups move to it, not necessarily because it's the lowest thing on the menu, lowest cost item. Communication is extremely important. Those transparency tools are vital to having an effective HSA program. And then hopefully we're going to see the federal government ease up the amount we can fund the HSAs so that that'll actually open up some flexibility in the plan designs a little bit more. Marketplace, kind of what's going on, trying to be unique, setting yourself apart. So we talked about student debt. Liz had touched on this, and one of the things we hear from employers is kind of, we got this great 401k plan, but these young kids are coming in, they're not even contributing. And in some cases, they actually can't. They may want to, but they can't. We all think, oh, they're just spending it on beer. Well, no, they want to buy a house, they want to get married, they want to do these things, but they come in with so much student debt that sometimes they can't. And basically what a student loan program can be is you put in place an administrative tool that helps you to help the employee with funding. And you can set aside a certain amount each month. You will help fund their account for them, help pay down that debt faster. Liz brought up signing bonuses. In lieu of a signing bonus, you could put out there that we're going to pay $1,000 towards your student loan debt for the first 12 months that you're here. And then you can scale it down over the course of time. It's a very flexible benefit. It's not subject to ERISA rules with discrimination. So you can use this as a recruiting tool as opposed to giving it to everybody, but you can certainly give it to everybody and use it as a retaining tool as well. Very inexpensive to administer. So really the budget for this is determined by how much you want to fund it. But there are a couple new tools in the marketplace that we work with, and we can certainly help you with that if you'd like to talk about putting it in place. Calling Dr. Skype, telemedicine, this is kind of a neat thing. As of January, every insurer in Massachusetts will have this tool available. Most of them have already had it. But it's basically kind of calling up a doctor on your smartphone or your computer and having a virtual office visit. There's a lot of different uses for it, certainly the medical, but also behavioral health. It's 24/7 access, so it has a lot of advantages, but it's very low cost, very efficient. So it's something that a lot of the insurers are pushing because of that low cost aspect of it. And it's very accessible, so if you have employees who are on the road a lot, busy families, things like that, it becomes a very accessible tool. And doctors are able to actually prescribe treatments, prescribe medications. Now there are some proponents of it or some opposition to it in the sense that a lot of it is from our local doctors. They don't like these tools so much because it takes care away from them, understandably. And a lot of times when you're using these services, the information doesn't get to them. So you've been treated by an online doctor and prescribed something, that information doesn't necessarily get to your primary care doctor. Tufts is actually putting in a tool that will allow that to happen. So when you start your visit with your virtual doctor, it's not a virtual doctor, it's a virtual visit, I'm sorry. The doctor's real. But start the visit, you'll be asked if it's okay to share the information with your primary care doctor afterwards. So I think that's a good way to do it. There are some people who think there could be inappropriate use. If you're somebody who's looking to get prescriptions for pain medication, sorry. I think I need a script for something. But inappropriate use, and then security as well. Yeah, no kidding. Calling in. I'm going to tap out. Security of the data, certainly another aspect of it. Liz touched on how cybersecurity is such a hot topic right now. I know my data is somewhere in the dark web. I'm pretty sure. All these commercials tell me that. So second opinion services is another great tool that's out there. You're at the doctor's office and you have that oh my God moment. Not the good kind, but they just told you something that's a little bit scary. And the fact is that medical errors are made every day. Medical errors lead to higher costs in care. They lead to wrong care. In some cases, that can be very detrimental to your health. So expert second opinion services are available, but people don't necessarily use them. Sometimes doctors will even suggest them. So what employers are putting in place are different tools that make this far more accessible. And it's really scary when these tools are used. What happens? Because in approximately 70% of cases, a different treatment could be recommended. Now, that's crazy to think that many times they're recommending something different. It could be a tweak, it could be something small, but it could be something very different. In 40% of cases, they're actually changing the diagnosis. You're misdiagnosed. And these are a next level expert who's reviewing this. So, and then they're saying in 30% of the cases when you're recommended surgery, you don't actually need it. So second opinion services, they do a lot. They certainly reduce the cost because you're avoiding care that was unnecessary, but you're also avoiding care that may have been hurtful to your health or harmful to your health. So doctors actually welcome second opinions in most cases. So it's not like you're going behind your doctor's back by using these services. And there are a couple different companies that offer this. I think Consumer Medical, one of our clients, might be here today. They're one of the services that offer this to employers. All right, they are. And there are different ways to put this in place. As an employee benefit, it can be an option for participants. There can be incentive, so that if you're in a situation where this could be useful, we're going to incent you to use it by putting in maybe a gift card in there or a lower deductible for that type of situation, or it could be required as well. There could be a penalty in your plan that if you don't use it when you could have. You know, if you're requiring surgery, you have to use the service. Some of the other worksite wellness trends that are out there. We see a lot of health assessments, biometric screenings. These are great at benefit fairs. Certainly, the fitness and wellness challenges. A lot of you may have heard us talk about the walking challenge that we did at Insights. A lot of fun, very easy to do for an employer. And then smoking cessation programs. These are a little bit less used today, but certainly some employers still feel they have a big issue in that space. But what's growing in popularity would be things like mindfulness and mental health, meditation, yoga, a lot of things around that, becoming very popular benefits. The financial wellness tools, nutrition classes, bringing that into the workspace is another thing. We're sending out information about that. And then certainly work-life balance programs that are also very popular with employees. And then this is a neat one that we like out there. We call it a Better Vending Machine. And basically this is a company called Leanbox. And if you're an employer who has vending machines on site, this could be a great option for you. Leanbox puts a vending machine into your work site that has very healthy foods in it. They actually have a 90-10 mix, I think they call it. It's like 90% healthy stuff and then 10% kind of sweets that you're allowed to have too. So, but they make it very accessible because it's right there in the workplace. They also make it very cost effective for the employee. A lot of this stuff is stuff that you see at Whole Foods. It's very popular brands that you'll see there. They're full meals, they're drinks, they're snacks, but they make it offered at the cost of the good. Because the employer is paying for the service, the food is at cost. So you actually pay about 70% or 60% of what you would pay for the same product at Whole Foods. So very cool. And if they come out and they do a demo for you, they bring all kinds of food, which was kind of neat. We had a whole bunch of stuff in the office for a while there. But something you can take a look at, certainly. And there are a couple of insurers that if you use that service, it's a little bit of a discount. So now we'll get into kind of some of the, it was the kind of the good, the bad, the ugly stuff. This is the ugly stuff. The Affordable Care Act, final vote this week. I'm not sure they're actually going to vote. They may not vote on it, but you know, you probably heard the news, the Graham Cassidy bill, the skinny bill failed back in July, sorry. But the Graham Cassidy bill is on the table. Senators McCain, Murkowski, and Collins all said no. So those are the votes they needed, and at this point there are no votes. Collins came out over the weekend and said no. She was kind of the last swing piece that they had hoped for, and it's a bit of a change. So this bill, you know, you had a situation where each of the versions of the bills were kind of coming down a road to meet the others, and they were kind of coming this way. And then with this Graham Cassidy bill, they kind of took a turn and said, meet us over here. It's a different animal. It uses block grants for the states instead of what they were doing before. And so it's a divergence, and I don't know if that helped them or hurt them in this process, but it's looking like it hurt getting any kind of reconciliation bill through. They have to do a reconciliation bill by the end of this week. The 30th is the deadline. After that, the only option is to rip and replace the ACA. So at this point, it looks, the outlook isn't good for changing the ACA. Or it might be good that it's not changing. That's the other thing. So just kind of in summary, some of the changes in the Graham Cassidy bill. It does repeal the individual and employer mandates. It doesn't take out the reporting function though. You can't, because it's a reconciliation bill. You can only change things that cost money. Medicaid expansion dramatically gets pulled back, and that's the biggest point of contention. Massachusetts was one of the largest Medicaid expansions, so we're really hurt by this version of the bill. We were hurt by the old bill. So it would be very detrimental to Massachusetts if this did go through. And then the premium, from a cost standpoint, I'm speaking. Premium tax credits also would be pulled back, and those over time. Things that would change, the taxes, so the HIT tax I mentioned, that goes away. The Cadillac tax doesn't though. Some of the industry taxes would go away. Central health benefits gets tweaked. Pre-existing conditions, you may have heard them say that this still protects it. It does, but it's not full-blown protection like we have under the ACA or Massachusetts rules. It does allow for some penalties for pre-existing. Prohibitions on annual and lifetime limits, we had that. It would get tweaked and allow for some planned flexibility around that. HSA funding could go up. And then coverage to age 26, that would stay. You know, pretty much everyone likes that piece, I think. Reporting for the ACA doesn't change a whole lot. Transitional relief is no longer available because we're a couple of years into it. And then there's some additional instructions on there. And those are just the dates that you have to file by. If you're subject to it. Also, the good faith stuff is gone. So now, you know, if you tried hard, it was okay. Now you really got to try hard. It's got to be right. So this is something new. A lot of you have probably heard about the Mass Fair Share contribution coming back. So this is going to be effective January 1st, and basically it's to help fund the Medicaid funding gap here in Massachusetts. We've got a big issue that we have to fund, and it applies to employers with 6 or more employees. It's going to apply to both full-time and part-time employees. There was some legislation out there that would put some reforms on Medicaid in terms of access, but those were taken off the table by the legislators. They said only the penalties can go into place. The only concession they got was that the unemployment insurance increase that got pulled back slightly. But there is some interesting things that have come up just recently. Governor Baker has formally petitioned the Health and Human Services to exempt Massachusetts employers from ACA reporting, which sounds great, but in place of that, we would go back to the old fair share reporting. And he actually mentions in the waiver wording that Massachusetts employers are familiar with the way we used to do it, so we can just go back to that. Well, that was 7 or 8 years ago, and the systems we used then don't exist anymore. We have new payroll systems, and so that would all have to be rebuilt. And if anyone remembers that, it was painful. But this is just an outline of how it works. Basically, everybody pretty much gets hit with the top tier piece. The EMAC, the Employer Medical Assistance Contribution, is built into your UI. You pay about $51 per employee currently. You'll pay about $77 next year. But tier 2 is the targeted penalty. This is for employers that have employees who are accessing Mass Health. If you have a non-disabled employee accessing Mass Health, you would be penalized. You would pay up to 5% of their wages, capped at $15,000 of wages. So that's basically a $750 contribution for an employee who works for you. So that one, I mean, there's a target on the backs of certain industries. Certainly, you look at the hospitality industry, any seasonal industries, that this is one that was really going to weigh heavy on them in terms of penalties. But even a lot of larger employers, they have people using Mass Health. So you could get hit with this. Nonprofit exemption, there is an exemption for nonprofit employers. I'm going into extra innings, Mike, just so you know.
No, I'm just making sure you don't.
No, just one more slide, don't worry about it. But we need some guidance on this. So the regs on this haven't been published. We have a lot of not-for-profit clients. We think they'll all be fine on this one. We just need to know what the exact wording is. But just keep in mind, this is part-time and full-time employees. We don't know how it's going to work logistically when your employee has 3 jobs, that kind of thing. Who's really paying all that? But that's the way it's going to work. And then last, I just want to mention, if anyone has employees in New York, the New York Family Paid Leave Law is very important because this also goes into effect January 1st. New York Family Paid Leave is similar to some other state leave programs. It's going to provide paid family leave. The first year it's in place, it's 8 weeks, but it will expand to 12 weeks of paid family leave over the course of the next 4 years. And it basically works a lot like an FMLA leave, but you have to be paid for it. It is funded through employee contributions, and there's a benefit of about 50% of the employee's wage up to $652, and the employee funds it with a payroll deduction. And I do want to point out an error. If any New York employees or employers are in the room, I put that the deduction was capped at $1.63. It's actually $1.65. I noticed that this morning. So, but you can start the deductions now, so that when you get the bill in January, you have money to pay it. But most employers that we work with have said we're just going to start in December, that kind of thing, because it's not going to be a whole lot of money. You know, you'll be able to fund it in advance, and then it has to be with a New York DBL carrier. So anyone who has New York DBL, this applies to you. And your New York DBL has to be the administrator of this. They'll be the one that bills you for this program. There are a few other states that have paid family leave. California, Rhode Island, and New Jersey all have it, but they're payroll taxes that fund it, and it's administered by the government. With this one, it's separate. It's going to be administered by your New York DBL carrier. So if it affects you and we haven't talked to you yet, just let us know. We'll certainly fill you in on what you need to do. It's not a whole lot, but this does take effect in January. The penalty is bigger than what you would pay out in the insurance premiums anyway. So certainly a good idea to do it.